Okay, good morning, Otixident team. Could you just confirm that you hear me well? And then we can start. Good. Okay, so I switch to now the presentation, and if there is anything, I will maybe not leave my telephone on, but I trust you can send me a message. Hopefully so. But normally everything should be all right. If really you need to interact with me, I trust you can reactivate your microphone and give me some instructions. Okay? Hello, good evening, everyone. This is Didier Dietschi speaking from Geneva in Switzerland. I'm here together with Otixident team for this webinar series on TUSWare. Today we'll have the part one. The part one regarding interceptive and ultra-conservative treatment of TUSWare. The part one will be dedicated to diagnosis, risk factors, and modern treatment strategies. The part two will be dedicated to direct interceptive treatment strategies and clinical protocols. And the part three will be about indirect and hybrid treatment strategies and clinical protocols. Just for you to understand what is hybrid. Hybrid means some of the teeth will be restored with an indirect or CAD/CAM approach, and some of the teeth with a direct technique. The aim is to use the most appropriate technique and restorative material to different levels of tooth wear within the mouth, and also to take into consideration the individual biomechanical status of each tooth. So now to come about the treatment strategy. Tooth wear is maybe not regarded as the most sexy type of treatment, because a lot of what we do relates to function and will happen on the back teeth. It's maybe not the most exciting treatment for the same reasons I mentioned, because it is not as simple and spectacular sometimes as doing veneers or bleaching and direct composites. But it is one of the most challenging treatments because it involves biology, it involves function, it involves biomechanics. And also, you need to have a relatively good understanding about the properties of the restorative materials you will apply to tooth wear treatments. It is for sure a timely topic. I'm not saying that decays and periodontal diseases have disappeared from our world, from far not, but their incidence is constantly going down. And unfortunately, when one pathology is being eliminated, another one is emerging. So erosion and attrition have become a fundamental aspect of global rehabilitations. I can hardly think about any patient who I treated recently for a comprehensive global treatment where tooth wear was not involved. So it became one of the most prevalent reason for global rehabilitations or complex rehabilitations. So today I would like to make some general considerations and discuss in detail the diagnosis. Because without a proper diagnosis, there isn't really any proper treatment planning and execution. What we know from the literature, and I don't want to bother you with a lot of literature references, but there is an increasing incidence and prevalence of tooth wear already from young generations. It starts with teenagers, young adults. And of course, when you observe tooth wear signs in an adolescent, teenager, or young adult, it's very important to install preventive measures. In order to avoid, even though that is a relatively extreme situation, because bulimia nervosa or anorexia can lead to extreme tooth wear severity. But even in those cases, taking the right preventive measures or interceptive measures might help the patient to avoid a dramatic situation. You will see this patient a little bit later. This is another view of the same patient with really the disturbing findings for me of patients who have been regularly visiting their dentist but never got the right support from the dental team, and we let them somehow evolve up to that situation. Something which is interesting, however, is that the majority of patients consulting for tooth wear do not consult because of pain, do not consult because of functional problems, do not even consult because of dentin hypersensitivity. They consult because of the impact of tooth wear on aesthetics, and somehow it is good that they get concerned, at least by the changing appearance of their smile. So you see here the percentages presented by the group of Milosevic, and it shows very clearly that the majority of patients are being more aware of the aesthetic impact of tooth wear on their dentition rather than by any other problem. What we also know is that when we lose posterior support, so when you have edentulous posterior areas, the concentration of stresses on the front teeth will, of course, create more severe anterior tooth wear. But that's somehow logical, and that's something known since a long time. You see here a perfect example of what I said before. This patient had no perception of any biological or functional problem, any hypersensitivity, pain whatsoever. She was only concerned by the flattening of her smile line, and the aesthetic impact of tooth wear was her only concern. But let's have a look at what happened on the back teeth. You see here the lower half of your teeth with nearly complete erosion, maybe erosion attrition, because very often it's a combination of both phenomenon or risk factors, but you have nearly no enamel to protect the dentin, especially on the side where there are only small restorations. On the upper arch, you have very obvious signs of erosion, a little bit less on the second molars, because they are probably better protected by saliva coming from the parotidis saliva glands. And if you look at the upper front teeth, you see that we lost a significant amount of tooth structure. Not only have we lost completely enamel, palatal enamel, but when the function happens on dentin, which is a less wear-resistant tissue, then of course you lose even faster tooth structure. So the question on a case like this is, what shall we do? Is the severity of tooth wear so important that we need to think about a full mouth rehabilitation with CAD/CAM restorations or indirect restorations? Shall we use composite? Shall we use ceramics? Or do we need to think about something a little bit simpler, what I call interceptive? This is what we try to implement when we have the chance to treat the patient before we move to a more severe situation. But I'll come back to the details of this strategy a little later. So now let's discuss in more details the etiology. and how this will impact the prognosis of tooth wear, and as well, as I said before, the selection of the restorative material and the restorative approach. First, let's just make sure that we understand each other. Erosion is, of course, induced by acids, exogen or endogen sources of acid. Abrasion is mechanically induced. Usually we relate abrasion to the use of an object. It could be a toothbrush or some foreign objects on which we bite. Attrition is basically the movement of teeth in between each other. So it exists from physiological levels up to pathological levels. The threshold between physiological and pathological is, of course, something that is still under intense debate. Abfraction is a peculiar type of tooth wear located mainly in the cervical. And what is important to understand, and I will come back to this in a little moment, we have combined etiology. So we have two or more phenomena superposed, acting synergistically to provoke loss of tooth structure. And sometimes the diagnosis is a little more difficult. Tooth wear is a general term. It doesn't relate specifically to erosion or attrition, let's say to an acid-induced or mechanically induced loss of tooth structure. Let's start with erosion. I'll go relatively quickly on this part because I trust it is globally more or less well understood in the dental profession. It can relate to diet, reflux, so acid coming from the stomach, and some very severe forms of normally pathologies leading to very severe forms of tooth wear, bulimia, or anorexia is nearly the same problem. The difference is that bulimic patients, they eat a lot before they vomit. With anorexia, patients tend also to vomit, but they eat less. So the result, of course, is much more obvious on their body weight. The question will be whether we can control it or not. But this is something I might not have the time to debate in length here. So you see here one of the most severe forms of erosion in a case of bulimia. You can observe, I will just activate my laser pointer. You see here the extreme loss of tooth structure. So basically the entire occlusal anatomy has disappeared. And here we have lost maybe more than 1/2 or 2/3 of the occlusal tooth volume. A little bit less severe here related to important improper diet that led the patient to eat a lot of vegetables, especially in the form of salad with a lot of vinegar, combined to regular consumption of fizzy drinks. So both things together, of course, created a significant loss of tooth structure. And again, here you see that we have nearly no enamel left. You have this typical appearance of occlusal or palatal surfaces, even sometimes facial, related to erosion. Another case with typical hollowed lesions related to erosion. And you see that we went progressively to less severe cases. So which are the typical findings, clinical findings related to erosion pathology? Hollowed occlusal lesions is one of the most common. Facial and lingual enamel flattening. Rapid tissue destruction depends, of course, on the type of erosion. Diet is less aggressive. Bulimia and anorexia are more creating more rapid tissue destruction. When the problem is related to diet, I'm not saying that the dental team as always, a very strong influence on diet management, but we can talk about it and we can help the patient trying to control her or his diet. The prognosis is not too bad. We clearly go for a conservative option. When I say conservative, that relates to the way we restore worn teeth. Conservative means we only protect worn surfaces. Protective means we might cover some surfaces which were not yet affected by tooth wear, but which might become at a later stage. Reflux, if it's diagnosed and if the patient received proper medical care, the conservative approach will be very successful and the prognosis normally is excellent. Bulimia, anorexia, as we all know, are more critical conditions. At the very beginning of this disease, it might be more difficult to control. In some cases, we might select a protective approach, so it means we might use form of restorations which will protect intact surfaces from further erosion. And the prognosis, of course, is not bad, but not really, at least it's not easy to control those cases medium and long term. You can never say that a bulimic or anorexic patient is healed forever, even though there are some patients who fortunately can get out of this pathology. Attrition, as I said, is age-related, and if it's a physiological process, this will be simply related to the age of the patient. This patient is 83 years of age. We can observe a significant tooth wear on the lower front teeth. Part of the teeth were restored with crowns, so it is a little bit less problems there. I'm personally more concerned by plaque accumulation, plaque control. How can we prevent decays to happen? If the patient has aesthetic concerns, we can always discuss this aspect. But here, we can't really say that it is a pathological situation when it comes to attrition. When you observe attrition in young patients, young adults, even teenagers, and you obviously face a rapid and pathological level of attrition, you need to think about awake or sleep bruxisms, clenching. Clenching is a form of bruxism, as you know, with only micro movement. So nearly the patient closes her or his teeth and is just creating force with very, very small movements. And that leads to different type of wear facets or attrition areas compared to bruxisms, where the patient tend to do more extensive protrusive and lateral protrusive movements. This patient is 36 years of age. There is no need for long debate to be able to say that it is clearly pathological. By the way, a recent consensus conference brought tooth wear to a new status of a non-pathological situation, which I think is completely absurd. When you see a case like this, it's clearly pathological. I would like to take the opportunity to make this remark that, generally speaking, the dental profession has not been very active in installing preventive measures for tooth wear. When we observe tooth wear in very young patients, it is critical to try to motivate the patient for diet control and night guard. And that has not been done in a very efficient way over the last couple of decades. So bringing this kind of pathology to a non-pathology status, I think, is the most absurd decision that I could have heard in regard to tooth wear. But okay, this is not here the place to make a long discussion about that. You have in different areas of the mouth some very clear lesions related to attrition here on the palate. It's moderate to severe here. Here it's clearly severe. Which are the main clinical findings in regard to attrition pathology? Flat wear facets, this is what you observe on the occlusal surfaces. Flattening of cusps, when you get lateral movements, of course, a cusp will be flattened, like inside the ledges. And you have those typical palatal indentations, which you have just seen on the previous case. Cervical abfraction is a peculiar type of mechanical tooth wear. I'll come back to this in a few seconds. So attrition is related mainly to parafunctional activities. Sleep bruxism is relatively easy to control with a night guard, so you can definitely use a conservative approach. We very much depend on the compliance of the patient, but we hope we can get this down the road. Awake bruxism is more difficult to control because very few patients will agree to wear a day guard. We might think about a day guard a little bit like Invisalign trays, appliances, and that shouldn't be that much disturbing. We can make it very thin, but I must admit that very few of my patients who have clearly awake parafunctions are compliant with a day guard. So I'm saying that usually it's a palliative approach which we use. Prognosis is not as good as when we treat sleep bruxism. And especially when you use composites to treat awake bruxism, it is like a mechanical switch. You interpose composite in between both arches, and you let the composite absorb the stresses and wear off, possibly have microchipping, but at least it happens on a restorative material and not anymore on the tooth structure. When you have a combination of awake and sleep bruxism, again, the prognosis relates a lot on the compliance of the patient with the night guard or day guard, if ever. But again, we can do something with composite, maybe before it goes too far, and that we need to install a more complex type of treatment. Abfraction has a lower incidence than the previous lesions we mentioned in regards to mechanical tooth wear. It's easily treated when it's early diagnosed because it concentrates on the cervical part of the tooth, and it's related to a tooth flexure. You get disruption of the enamel prisms, and it leads to lesions which develop toward the crown and not toward the root. And we need to differentiate this type of lesion from abrasion lesions related to recession. Because then when you get gingival recession, and I think looking at real teeth is easier, if you get gingival recession here, with tooth brushing, you will remove some dentin structure. But here you see it's typically happening into the enamel, and that's happening at the crown level. Sometimes you might have also a little bit of erosion, but here they are very typical non-carious cervical lesions related to abfraction. And you can see here, for instance, very severe wear facets also happening on the tips of the cuspids. But the flexion of these creates also some cervical lesions. You see it here in different views. This is not something that we observe in every single tooth wear case, but that's something that might be seen from time to time. What I found, because it's a long time, I'm very much interested into treatment of tooth wear, is that combined pathology, combination of risk factors, is probably the most prevalent type of tooth wear. You might have, of course, predominance of attrition or erosion, and this might even change over time. We should not have the view or the understanding that attrition or erosion is a phenomenon that take place in a regular way over time. you might get a predominant phase of erosion due to unbalanced diet for a given period. Then the patient is getting in control, might go through another form of stress, starts to grind teeth because of bruxism, maybe again enter a quieter phase of her life or his life, and then maybe you get a stable situation. So we needed to integrate the time factor and the possibility that not only we have imposed erosion and attrition, but with different predominance over time. You see here a typical example of combined tooth wear. You have the typical hollowed lesions of erosion. You have also typical wear facets. You have even fractures of marginal ridges. Some people give a lot more importance to erosive tooth wear, but that is not erosive tooth wear. This is clearly the sign of abnormal occlusal forces. With normal function, you will never fracture enamel at the marginal ridges. So here, you will never get this kind of micro. It was a small composite filling here. You see micro cracks. This is a sign of fatigue of the restorative material that doesn't happen if you don't have abnormal functional forces. So basically, when you have combined pathologies, you might observe all the previously mentioned, aforementioned type of lesions on the same teeth: flat and hollowed wear facets, flattening of cusps and incisal edges, flattening of lingual and facial surfaces, which is more erosion, abfraction and palatal indentations, which is more attrition and mechanical tooth wear. And overall, less typical hybrid lesions. Every time it seems to be more difficult to identify risk factors and pathologies, you need to think about hybrid type of lesions. And also knowing that this is one of the most common situations. There are indices to evaluate the severity of tooth wear, but I think it's very complex and it's more a research tool. I don't think we need to use any wear index when it comes to the clinical treatment or clinical approach to tooth wear. You need to look at 4 different parameters. What we have just discussed right now, the type of lesions that will lead to a diagnosis, mainly attrition, mainly erosion, or a combination of both. Then you want to know the extent of lesions. Is it primary, intermediate, or severe? If you look at the tooth wear index, you might get a lot more options, but I don't think, again, we need this for clinical practice. And then a very important factor, because this factor only doesn't give you the key to selecting the right treatment. You want to know the age of the patient. Moderate tooth wear or intermediate tooth wear in a teenager is a very severe condition. Moderate tooth wear in an elderly patient is just physiological. So it leads to complete different strategies. And a last factor that normally we do not know when we meet the patient for the first time is the compliance of the patient. We'll need the compliance of the patient to control her or his diet, to wear the night guard, to work together with us. Treating tooth wear is a team approach. If we don't get the cooperation of the patient, it will always be to some extent a failure long term. So we have, with the type of lesions, elements of diagnosis, and we have prognosis parameters, which are related to the extent of lesions or the severity of lesions, correlated to the age of the patient, and a third factor, which is very important, the compliance. But this, again, we don't necessarily know at the time we see the patient for a first consultation. So now, which treatment rationale can we follow? If you look at the literature, and this is a rather recent paper, which is about tooth wear treatment options, and it's a systematic review written by a group of experts in Europe, from Netherlands, from Germany, Daniel Edelhoff, Ivo Krejci from Geneva, and Dr. Kuhn, I'm not sure where he's from, to be honest. And analyzing different treatment strategies, they found relatively little agreement in regard to the different steps. Maybe a few steps are common to different strategies, like increasing vertical dimension of occlusion, but there is no consensus in regard to the occlusal positioning, whether you need always a diagnostic wax up, or if you test with an eye guard or with temporaries, what kind of restorative material. Follow-up, I think this is also one thing on which we agree. We need to follow up. We cannot do restorations and then wait for the patient to come back 10 years later. So I will share with you my own approach that is very different from this one. This is a very nice treatment documented and published on social medias. And you see here a moderate tooth wear situation, diastemas which are not necessarily related to tooth wear. And patient was beautifully treated using CAD/CAM technologies and modern technologies. But you see that this led to basically 28 CAD/CAM. I don't remember whether that was ceramic or composite restorations. But in my view, this is a wrong treatment approach. With all the due respect to the people who perform that treatment, it's not correct on a case like this to use the same time of restoration on all the teeth. It facilitates the approach, but we must have a more selective approach to tooth wear if we want to be conservative. That type of treatment leads to significant extra tooth loss, because if you start with a class 1, there is no way you can do indirect or CAD/CAM restorations without additional preparation. So I will share with you a philosophy which we started in the mid-90s, even before. That is a case of bulimia that I treated a couple of years before it was published in 1996. You see here the original article, so I'm not cheating with you in regards to my relatively long-term experience with treating tooth wear. And this treatment strategy is very much based on prevention, interception of treatment tooth wear, and also to use a combination of restorative materials and type of restoration. I don't go systematically direct on all the teeth or systematically indirect or CAD/CAM on all the teeth. I very often combine the type of restoration and materials, and that works perfectly well. It's not because we have differential tooth wear resistance that we cannot combine materials. With passive eruption, we'll maintain the teeth in occlusion, and there is nothing wrong with that, even though we were said that we need to use the same material throughout both arches, which is, I believe, not correct. So the first strategy that I would like to install for every single tooth wear case, if I will have the chance to see them early enough. Nygaard to prevent attrition, diet counseling, anti-acid drugs or psychotherapy for reflux or more severe forms of erosion like anorexia or bulimia. You see here a case with long-term follow-up. This is in 2018, and this is the beginning of the follow-up of this patient in 1994. So we have more than 20-year follow-up here. And I could identify here the first signs of tooth wear. It's a patient who has bruxism. Bruxism leads to, normally, if you have proper anterior and canine guidance, will lead first to wear of the teeth which are guiding in lateral protrusive movement. So you mainly start by observing wear facets on incisors and cuspids. And now you see 2018, that is basically 24 years later, if I calculate well. 22 years later, 26 years later, and you see that we lost very, very few additional to structure. But the patient has been wearing the night guard every single night. Not, unfortunately, every patient, but some patients, when they look at their night guard and they see what they do on the night guard, they start to think, I don't want to do this on my teeth. I prefer to do this on the plastic. And we get very successful. Unfortunately, we don't have the chance to install proper and efficient preventive measures early enough. There are some patients, they arrive to the practice and the severity, the degree of tooth wear is already too much advanced. And I need to think about another strategy. It's too early for a full mouth rehabilitation using indirect or CAD/CAM restorations. It's too late to install preventive measures. So this is the right indication for what we call interceptive treatment approach. We have many different options. We have direct freehand. We have direct molded, single or multiple, or partial or full molding. This is what I will explain during the part 2 of this webinar serial. And the shell technique, which is a molding technique, but made in the lab. That is sort of simplified, super simplified indirect technique. That is very easy and relatively inexpensive on the lab side. That is, for me, a typical indication for interceptive therapy. Patient is in the late 30s. We have obvious signs of erosion, but also attrition, even though here the clinical findings speak more in favor of erosion as the prevalent risk factor. But there are also, if you observe, for instance, here on the canine, you also see wear facets. But am I in a situation where I must advise the patient to go through 28 indirect or CAD/CAM restorations? Clearly not. No way. It's far too early. I will not be able to restore such a case indirect with no preparation. And that is, for me, in consideration of the overall mouth status, that will be criminal in a way. Sorry. Sometimes I like to be a little bit extreme in my statements, but I want to share with you these very important considerations, and that we can debate about this later on during the Q&A session. You see here also some abfraction, probably here combined abfraction and erosion lesions. Very difficult to make a proper diagnosis. I will not debate for an hour about the fact it is abfraction or erosion. We might have a little bit of recession too, so it could be also abrasion. So it might be a combination of different factors. So here, interceptive strategy means we sandblast. That's the only preparation. We have also taken the opportunity to remove the amalgams and to change the amalgams at the same time. And we apply direct composite to freehand the composite. This is done according to a wax up. This I will explain in details during the part 2. And at the end, this is what you get. You replace missing tissues, and you might protect a few areas. But here, the main target is to replace the missing tissues, reestablish occlusion on the restorative material. And then together with also preventive measures, because it doesn't mean that because we apply composite that we forget about prevention, we'll organize a night guard for the patient and we'll try to conceal the patient about diet. And this is the final view. Everything freehand, direct, no prep. The beauty of this is that it takes only a relatively short time. How much time do I need to build up one quadrant or one sextant? It's normally about an hour with placing the rubber dam and doing occlusal adjustments. I normally reserve one appointment of 3 hours per arch. If you have very small class 1 occlusal amalgams, doesn't really change the operative time. Only if you have several class 1 and 2, medium, large, to replace. Do this first, maintain the same vertical dimension of occlusion, and then you build up the occlusion. I see the patient again in 2016. I forgot to mention that the patient is not my patient. It was referred to me by colleagues, knowing that I do a lot of these interceptive treatments. So he has been under, let's say, follow-up at another dental practice. And the reality is that, unfortunately, the patient has been never really following our advices, diet advices, neither wearing the night guard. So what is the situation? After 6 years, no preventive measures at all. Some additional abfraction erosion, maybe a little bit more erosion or wear on some areas. Some areas here newly worn. I started by correcting the cervical restorations. And a little later, finally, the patient came back for some additional refreshing of the restorations. So maintenance implies sometimes a little addition of material. You see here the cervical lesions on the lower arch were restored. I haven't replaced, I've just added material. You place the rubber dam, you sandblast, and you add some additional material. And in 2018, I advised the patient to go for a second treatment phase, because you see that we lost here material on the canines, and at the level of the molars, it's very visible here on this view. You get a flattening of the cusps, which we had built it up with compounded. So what we did in 2018, we went through a second phase of purely additive restorative material. So we placed a rubber dam, we sandblast, we add material to reestablish canine guidance. It's very important. We like canine guidance when we use composite, because that will reduce shear and tensile forces on the composite during lateral movements. If you use ceramics, there are some other occlusal concepts you can follow. And this is the situation after the second additive phase. Usually we can go with a second, possibly a third phase of material addition. And that will already here, we are 8 years post-treatment. We might usually go for 10 years, 12 years, even a little bit more, with a completely no prep approach, with a very cost-effective treatment approach. This can be done with a freehand technique, like here. It can be done with a molding technique that I will demonstrate during the second part of the webinar. We have many different excellent clinical protocols for this. In some conditions, as I said, severity of tooth wear doesn't allow easily to use just composite. Maybe also in case of severe parafunctions, composite might reach its mechanical limits. So in direct composite, especially CAD/CAM blocks, high-strength monolithic ceramics for partial restorations, mainly lithium disilicate, are favorites. They are our favorite materials. So here you see a situation with the patient suffering mainly of awake and sleep bruxism. The patient is a surgeon, medical surgeon, and he knows that he has relatively severe awake parafunctions. But he said, when I'm in the surgical room, for many different reasons, including probably hygiene reasons. I cannot come and put my tray or a day guard in the mouth. So I need relatively strong restorations. He's a very busy person. And he said, one of my main requests and expectations is that I might not need to come regularly for fixing little fractures, chipping. Because if you restore those teeth with composite, I'll be very clear, you will get chipping, possibly, probably even. So if the patient really looks for a very stable type of restorations, maybe on the incisors, you might look for another material. Same for the second molars or the molars. You see the situation on the back teeth. You see here the level of tissue destruction on the upper front teeth. We have nearly no tooth wear on the upper back teeth, a little bit more on the lower back. This is more signs of clenching when you get this concave occlusal anatomy. We have some cracks on some molars. We might be able to improve a little bit the alignment of the second premolars in the lower arch as well. So here we did a pre-treatment wax up, mainly to set up the new video. We normally can increase up to 5 millimeters with nearly 100% adaptation of the patient, but we probably never need to increase 5 millimeters. 5 millimeters is calculated at the front or inside the levels, not on the back teeth, of course. So here we used, anyway, a hybrid approach. So we used mainly indirect restorations, but also a couple of direct restorations with the flow shell technique that I will detail next week. Since we have the wax up, we're going to use the wax up to fabricate indexes. And for instance, on the lower front teeth, where the composite will work mainly in compression, and in compression, composites, even direct composites, are relatively good materials. I will use a direct approach. So it's going to be 100% no prep. And that is the post-treatment view on the lower front. It's very easy to get a smooth optical transition from the composite to the tooth structure. It's a simple clinical protocol. And on the back teeth, I've used Emax Press. If you go for thin overlays, I personally prefer to go with Emax Press. Emax Press is not only a little bit stronger at the time of processing, of fabrication, but I don't want to bother you with the literature here. But in a human environment with fatigue, Emax CAD/CAM will use nearly half of its mechanical performance, while Emax Press or lithium disilicate pressed might lose only a small part of its mechanical resistance. So based also on a clinical study from the group of Daniel Edelhoff in Munich University, here on 200 lithium disilicate restorations made of Emax Press, provided you have more than 1 millimeter occlusal thickness, they had no failures. This dissertation wasn't published, unfortunately, so that might be the only reference of this work that you might find here. So we used stained and glazed restorations for the lower molars, because we increased actually the video only on one side. It was no need to do it on the other side, on the antagonist upper arch. And we used only 4 Emax 360 veneers for the upper incisors and direct composite for the lower incisors, as you know. Of course, with stained and glazed restorations, you don't get the ultimate in terms of aesthetics. A little bit of veneering with aesthetic porcelain will be desired for extremely demanding patients. But this patient had the wish for better aesthetics, but also he was aware of his tooth wear problem, and he wanted to stop the problem. He's very compliant with the night guard. And I think this is a beautiful example of the combination of direct and indirect. This selective strategy where we try to restore the minimum number of teeth to stabilize the problem, to protect worn surfaces, to establish better aesthetics, better function. You will see next week, the third webinar will be dedicated to hybrid and indirect. I'll show you also at least one case of more indirect rehabilitation in a very severe tooth wear case, rehabilitation of a bulimic patient. This is 1 year later. Of course, there is no change. Even the canines, the upper canines were restored, were not restored, or with just on this side with a little bit of composite. And this is the lower front teeth. Of course, it's only 1 year. Patient has awake bruxism. There are small wear facets. The wear facets will expand a little bit the contact surface, and then that will lower a little bit the wear. At the very beginning, when we have a little bit sharper anatomy, of course, the wear starts a little bit faster, and then the wear rate is progressively reduced while we slightly enlarge the contact areas. And you see here the occlusal anatomy, about 1 millimeter thick overlays on the lower back teeth, direct on the lower front teeth, a few indirect on the upper incisors. In fact, it's coming. I just prepared the last case, in fact, for you. That's very good. I had forgotten. Sorry for that. It is the treatment of the bulimic patient you have seen before. And I would like to spend a minute discussing this view and the next one. This was in 2006 when the patient came to me for a first consultation. He was suggested to go through a full mask indirect rehabilitation, and he was only looking for a second opinion. So I said, I think overall it's correct. Maybe we might do a little bit of composite, direct composite on the lower front, but globally this is a correct approach. Due to financial reasons, and this is one problem. If you wait too long, then financial limitations might prevent the patient to go early enough into the treatment. And this is 10 years later. Finally, the patient came back. He was not convinced about, being treated in the previous practice, where he had very seldom, in fact, check. And you see that he basically only went in emergency to get endodontic treatments performed. And you see the disaster. Because in bulimic patients, vomiting regularly, of course, impacts caries resistance. So if the patient has a high caries risk with the bulimia or anorexia, this will worsen the situation. So as you can see here, this tooth is irrational to treat. As this one we tried, but the decay was arriving basically in the furcation. So finally we extracted the second molar and the wisdom teeth in the 4 quadrants. This is at the end of the therapy. So that involved implants. It involves also this protective approach I mentioned before. So we go with very thin preparations, but it's more like crowns, or we call it today 360 veneers, on the majority of teeth in order to protect those teeth from further erosion. This is the upper arch. So you see it's a little bit different from classical crown preparations. We did the same on the upper front teeth. And at least we could save a couple of teeth for a direct approach. I will always try to save a couple of teeth from full coverage. And lower incisors are well protected by saliva. So normally you have limited erosion on the lingual. And again, composite, when you build up the incisal edges and tip of the lower cuspids, as the composite works mainly in compression, it behaves really, really well. This is the view of how much we augmented the clinical crown of upper front teeth. We used here, I'm sorry, it's a little mistake here, forgot to correct. It's not stratified at all. It's only stained and glazed. Our dental technician, Serge Erpen, has done a wonderful work on this case. Of course, again, it cannot be as beautiful as stratified restorations, but you can imagine on a case like this, the strength is the main issue. I'm not allowed to show you face pictures, but the patient is very squarish. He's a very, very strong guy with a very squarish face morphotype, and that's why we went with rather flat and squarish teeth. This is what we call visagism, to try to adapt the tooth form to the face form. That is the final treatment. It has been a long journey to get to that result. You see now on radiographs the amount of dentistry that finally got involved in such a severe tooth wear case. So what is the learning? What is the learning experience from seeing from time to time such patient? Is that we as the dental profession, we failed to install preventive and also interceptive therapies before. My point today is that we should nearly never face that kind of treatment. It means together with the patient, I'm not saying the patient has no responsibility, but I'm sure that knowing, for instance, this patient, I know that this patient I could have handled much earlier if he was my patient before. So I will, of course, detail this kind of treatment in the part 3 of our webinar serial. And I will go through all the step-by-step. I will just come back both for the direct techniques or interceptive methods and restorative methods. I will start, of course, from the diagnosis. Attrition and erosion or combined pathologies might impact our decisions. Of course, we need to sometimes look a little bit deeper below the surface, do a diet analysis, pHmetry, or gastroscopy, depending on the conditions. Erosion pathologies. We'll go through the lab diagnostic. Where do we need a partial wax up? Where do we need a full wax up to reestablish the new smile line and the new vertical dimension of occlusion? We'll detail those steps. We might have a quick discussion about the occlusal concept. Do we restore all the cases in centric relationship or maximal intercuspidation or other occlusal positioning? We'll probably implement, I will not have a lot of time to discuss this, but I will try to implement the factor of tooth vitality or eventually the impact of cracked tooth syndrome or endodontically treated teeth in regard to the selection of restorative material. For vital teeth, I think it's very open. You can use composite or ceramics, depending on the severity of tooth wear. If you have cracked teeth or non-vital teeth, I will definitely favor indirect ceramics. So this was basically a very short overview of what's coming in the part 2 and the part 3. I'm looking forward already to meet everyone during the next webinars. But as a reminder, if someone is joined during this webinar, the part 2 will be dedicated to direct and interceptive treatment strategies and clinical protocols. The part 3 will be about indirect and hybrid treatment strategies. Now you know what hybrid means. We use a combination of ceramics and composite, combination of direct and indirect, and of course, the related clinical protocols. So I really thank you so very much for your kind attention. It has been a pleasure to talk to you today. I think we'll have just a few minutes or a few seconds. I don't know. It depends on the technical situation before we can start our Q&A answer session. Thank you already for listening. Thank you to the Otixident team for for organizing everything so well. And speak to you in a few seconds. Thank you. Can you confirm that the sound is okay? Okay, I wait for your feedback regarding the sound. So I think now we are ready to take the questions. So we wait for the first question to appear on the chat window. I hope everybody is ready for an interesting Q&A session. So yes, now we have the first question from Claudia. Good evening, Claudia. The question of Claudia is about the type of night guard which we recommend. This is a very good question. We might come back to this during the next 2 webinars, but I'll be happy to make already a first comment. If we are not in presence of a TMD case, means temporal mandibular disorder patient, the role of the night guard is mainly to protect. I like to call it a mechanical fuse. So it's just there to protect the teeth from further wear and the restoration from additional functional forces that will, of course, trigger wear and possibly also microchipping. So the material that we normally like to use is a heat-formed plastic. One company which is very well known to produce this kind of material is Ercodent. It is a German company. They have a lot of different machines. They are fabricated with vacuum technique after heating up the foil. So we use normally hard plastic. The standard thickness is 1.5 millimeter. We can go up to 2 millimeters for severe tooth wear cases, attrition cases. And for less severe attrition cases, when it is the very first night guard, we can go down to 1 millimeter, which is a little bit easier for getting adapted to this kind of night guard. Another material that we can use sometimes is a hybrid foil. It's hard on the outside and soft on the inside. This is normally a 2 millimeter thick foil. It's a little bit bigger, but it's very comfortable. That is for the patients who don't like the sensation of a tight plastic, hard plastic night guard. Those are the most common night guards which we fabricate. And unless we have specific reasons to place it on the upper arch, we normally have it on the lower arch because it's a little bit more comfortable to wear. It's less visible. It is the most comfortable option. Once in a while, if we have more restorations in the upper arch, we might also do it in the upper arch. It's not mandatory to have it on one arch or the other, but it's a little bit easier for the patients to wear it on the lower, what they normally say. Okay, the second question is for from Christina. Good evening, Christina. Thank you for your kind comment. The question is about air abrasion if we do it before etching, and it is not the same as airflow. Yes, you are absolutely correct. Air abrasion is using a different type of powder. This is normally aluminum oxide powder. You can use different grain size. I would say the most common grain size is from 25 to 50 microns. The majority of sandblasting devices are only with the powder and compressed air. Couple of devices also include water, but then they are not surface preparation. They are more real preparation devices. It was very popular, I would say, 15, nearly 20 years ago. Air abrasion was very often used for micro preparations, a little bit less by today. The advantage of using water is that it is cleaner, but again, it is very efficient, maybe a little bit too much for what we wish to do. So a regular sandblaster or micro etcher, as we call them, is something that you can connect to the turbine with this aluminum oxide 25 to 50 micron powder, and this you will perform before you do the etching. Etching depends a little bit on the adhesive system which you use. If you use what is my preference, a three-step etch and rinse, you might do first the etching of enamel, you wait a little bit, then you etch the entire surface, including denting for another normally 10 to 15 seconds before rinsing. But clearly, sandblasting is made before you proceed with adhesion, and preferably with the rubber dam in place, because the powder tends to go a little bit everywhere. And this is one of the many benefits of the rubber dam, is that it prevents the patient to swallow this powder. So thank you, Christina, for your question. The next question is from Savita. Good evening, Savita. The question is about the use of Facebook during the planning phase, and that would eventually serve for the wax-up. You're absolutely correct. We use a Facebook, especially in case we have some asymmetrical occlusal plane. Part of the initial evaluation is to check, of course, the horizontality or the correspondence between the occlusal plane and the bipupillary line. And this is one very important indication. Otherwise, if you do the wax up, if you don't have the horizontal reference plane, the technician has no reference to build up the wax up. So thank you for asking the question. This is absolutely clear. Which composite do we recommend? It is a simple question, but it's a very normally a very complex answer to provide. So I will do my very best to provide for today a relatively simple answer. I would say that by today there are maybe few composite technologies which are not appropriate for tooth wear cases. Those few technologies are microfiller, microfilled composites using microfillers. We use less and less of those composites, but there are still a couple of them on the market. And a few spherical composites, like, for instance, some of the Tokuyama materials. They have been developed mainly for use on the anterior sector. But even within those materials, you have different type of composite masses, which have slight variations in their filler technology. But in general, every microhybrid or the most recent nanohybrids work well for this application. Some materials, even spherical, sort of spherical materials like Filtek Supreme, they also work well for this use. I'm sorry, I'm trying not to use too many brand names, because brand names vary a lot from one country or one region to the other. So you might not really be sure what I'm referring to. So that's why I'm trying to be as generic as possible. And the last part of Savita's question is about the reaction of IMAX to different light conditions. That is actually still a problem by today. What Savita is referring to is what we call metamerism. Metamerism is, in fact, the interaction between light quality and translucent materials. depending on the light temperature, the color rendering index, it means it is the composition of light according to the spectrum of the different light colors. Natural visible light comprises all the different colors of the visible spectrum. Some artificial lights don't. This is one factor. A last factor might be the light intensity. But just to give very simple examples in order to understand why Emax and similar lithium silicate or lithium disilicate materials might respond differently under different light conditions. If you look at restorations with very low light intensity, like for instance in a restaurant with candles, you have a very low light temperature, which might be down to maybe 2,500 degrees Kelvin with very low light intensity, versus, for instance, looking at restorations during a cloudy day. In the middle of the day, the light intensity is very high and the light temperature can be up to 20,000 Kelvin. And with such extreme light conditions, many restorative materials, mainly ceramics, tend to look slightly different. And for some patients, it might be actually a problem. There is another issue with reaction to fluorescent light. So it is not easy. It is not easy with ceramics to find materials that show exactly the same as natural things. In this regard, composite behaves relatively well. The metamerism of composite is relatively limited, is markedly inferior to the variations observed with ceramics in general. Feldspathic ceramics were relatively good in this regard, but many other modern high-strength ceramics have some problems of metamerism. And that's something to check. How do we check? It's not so easy. We don't have now in the private practice specific devices which allow you to check different light temperatures. So it is a little bit, it might be some that I don't know, but you can get such lights into public, let's say, electronic shops. There are some LED lights which give you the possibility to check different light temperatures, but you will not get it normally from a dental company. You need to look for it either on internet or in a light shop. Sorry to have been a little bit long on that question, but I think it's a very important one, because if we do not control the metamerism, that might create really problems for some patients. So thank you, Savita. Question now from Ta. Good evening, Ta. The question is basically the same. I think that was the same answer that I have already given from a question of Claudia. Maybe you might have not been connected at the very beginning, so I repeat the answer very, very briefly. We use heat-formed trays, which are fabricated with special plastic foils, which have been developed for this application. One of the most known companies in fabricating the devices and the plastic foils is Ercodent. It's a German company. You have a couple of others, but this is one of the most well-known companies in this domain. We normally use hard plastics, standard thickness 1.5 millimeter, and you can vary from 1 to 2 millimeters depending on the severity of bruxism. A last option is to use a hybrid foil with a hard plastic on the outside and a soft plastic on the inside, but that's only for 2 millimeters thick night guards. Again, the material which we use is the one from Ercodent. So thank you for your question, Tam. Question from Fanas. Good evening, Fanas. Can you please give your opinion about using gold as indirect restriction in non-aesthetic zone? That is That is a very interesting question. Gold might be still by today one of the best materials when it comes to resisting to functional wear and functional forces. It is incredibly stable in the mouth, and I would absolutely not object this option. We have modern alternatives to this because gold, normally, if you want to beneficiate from the longevity of gold, I would say we need to stick to the classical cementation with zinc phosphate cement. If you bond with an adhesive technique, which is feasible, of course, technically, but then the aging of the margins is not as good as with classical cementation. But that has obvious limitations in terms of the geometry because we cannot do a flat overlay. I've done it, to be honest. I've done it on a few occasions. I'm just a little bit unsatisfied with the aging of the margins, but in regard to the restoration itself, that works perfectly well. I didn't do it very recently, as you might imagine, but it is definitely a feasible solution if the patient doesn't mind the color. IMAX is, of course, not as strong as metals. Even zirconia is not as strong as gold, but it's very easy to bond. It's highly aesthetic, and as you know, high-strength ceramics are good alternatives today to gold if you get minimum thickness. If you think about using lithium disilicate, and let's take IMAX as our reference material, you need to go not below 1 millimeter. And if you are treating a heavy Bruxer case you should prefer IMAX Press rather than IMAX CAD. Not only is the strengths, both flexural strengths and fracture toughness of IMAX Press a little bit higher at the beginning, but within the oral cavity, with chemical or let's say the impact of moisture and fatigue, we are losing a significant proportion of mechanical properties of IMAX CAD. So we don't use IMAX CAD for severe attrition cases, only IMAX Press. And if you like CAD-CAM technology, you use the CAD-CAM to fabricate the wax, and then you can press your IMAX overlays or tabletop veneers, whatever. So thank you very much for this very interesting question, Farnaz. Now we have a question from Krasimir. Good evening, Krasimir. Question is, do you remove the old restorative material during the second additive treatment? That is a very good question. I haven't gone now in this first part in any details. So this I will certainly present a little bit more in depth, but I have the opportunity already to give you an answer by today. If the restorations do not present any leakage or you see an obvious gap, it looks like the restoration is not well bonded anymore to structure, we normally replace the existing composite or ceramic restorations at the same video before we do the correction of the video. So we would have a first preparation phase with class 1 and 2 composite or etchable ceramic restorations, and then you can do the corrections with direct composite if this is your protocol. If it is indirect or CAD-CAM, I personally tend to do a little bit more direct or indirect pressed ceramics. I do from time to time also CAD-CAM composite, but I think the benefit versus a traditional composite is maybe not so spectacular. But even if you use something indirect or CAD-CAM and you want to go over existing composite restorations, once again, check that you have no recurrent decays, check the X-rays, check with transillumination, check clinically. If the margins are clean, no problem. If you only have slight discoloration of the margins, you might be just sandblasting. During this so-called preparation, which is sandblasting, you can clean the margins. And if you feel, unfortunately, you feel that you cannot get to a clean interface, maybe you can go with the burr and clean a little bit deeper the margins of the existing restorations. So thank you, Krasimir, for your question. The next question is from Anu. Good evening, Anu. Please, can you give any tips to do the composite build-up freehand, especially the labial and incisal surfaces? Thanks. That is actually, this is coming in the next webinars. But in fact, on the labial, also the palatal, and also for the occlusal surfaces for posterior restorations, we need to get a visual reference. And so the visual reference should be the wax up or the printed model from a digital wax up. We need to get this direct perception. If you choose the protocol of freehand, you need to get the physical example 3D in front of you. I think this is a much safer approach. I must admit that sharing this concept with colleagues have received some reluctance. People were skeptical. They were saying, but it seems to be very complicated, very difficult. Even with us, our own clinic many years ago, when I started to do a lot of those cases, my colleagues were very skeptical. They tried, and provided they have the wax up, and also you can use an index that is more for the build-up of the video. You will see the details during the second part of the webinar. When you build up the posterior occlusion, you fabricate a small index on the frontis that will allow you to get the visual control of the space which you want to restore, of course, before you insert the rubber dam. And then when you have restored the video, you can again set visually the space you have for building up the palatal or the labial. You see the forms, you see the new length, you can use an index. There are many different ways you can guide yourself. So I'll be a lot more detailed, so don't miss the webinar number 2, because I'll show you these different protocols, these different techniques we have for, I don't call it anymore freehand, I call it molded, but it's not always full molding. It might be just to use an index to control the height and the incisal edge build-up. Facial somehow still probably something that we do mainly freehand. But you will get more answers to your questions in the part 2 of the webinars. So thank you, Anu. Next question is from Elena. Is it possible to combine IMAX 360 on upper incisors and composite on lower incisors, or is it better to use IMAX on lower incisors too? You certainly, I don't know if you have experience to go with IMAX restorations, upper and lower arches. I don't want to say that it is not possible, it is not feasible. Of course, it is technically. The thing is that the first reaction of the patients is normally some sort of discomfort because it's very hard. They feel it very hard, especially if they had some composites before. So when you move from direct composites to IMAX, it might feel really very hard. It's more a matter of tissue conservation. If you go with the direct option, you can just build up purely additive, no prep. And this is the right concept. Unfortunately, it doesn't apply technically to every situation, but on the lower canine to canine, composites will work mainly in compression. It will wear off a little bit. That is absolutely true. But if it's not an extreme tooth wear case, and even I used this hybrid concept or selective treatment approach in so many cases now over the last 25 years that I can only tell you that works. That works with nearly no exceptions. The only thing you need to tell the patient, it will wear off a little bit. And I don't know, in 6, 7, 8, maybe even 10 years, you might need to add again a little bit of composites on the lower front teeth. And then you will have sort of Dahl's concept. Then the teeth will get a little bit intruded. Maybe the back teeth will do a slight supra eruption or passive eruption, and you will be back to your initial vertical dimension. This is really the Dahl's concept. So I would prefer to do that rather than to go with 360 preparations. If it is a severe erosion case and you have erosion on the lingual, then I think you can go with 360 veneers. I think that doing sort of a V-shape veneers or double veneer, lingual one veneer, facial another veneer, maybe having one material on one side and another material on the other side, that seems to be a little overcomplicated. There is some rationale behind it, but I think it's too expensive because to do 2 indirect restorations on the same tooth, it's probably too expensive. And I'm not sure that there is a very strong biomechanical rationale to save 1 millimeter of enamel in the contact area. You might have the risk that the margins become visible. I personally, if I really need to cover lingual and facial, I go clearly with a circumferential 360-degree preparation, but much less than for a regular crown. It's really veneer preparations, very conservative. Okay, so thank you very much. The next question is from Hannah. Amelogenesis imperfecta on a patient of 19. Is the rehabilitation possible with direct restorations? Intact teeth, big pulp chambers, almost no enamel. Is adhesion possible? We have treated a couple of amelogenesis imperfecta over the last couple of years, and the one that you referred to is probably an hypoplasic form of amelogenesis imperfecta. Dysplasic form. Hypoplasic forms, enamel might be a little bit under-contoured, might be full of little holes, but the enamel quality is not that bad. It's very easy to bond composite to it. But when it comes to dysplasic form, this is the one type of amelogenesis imperfecta that leads to more rapid erosion or wear. It's both chemical-mechanical destruction of enamel. I tried relatively recently to find some literature on what would be the ideal protocol to bond to this kind of tissue. And to be honest, I didn't find anything relevant. Clinical reports, but a clinical report, as you know, is not truly an evidence. So I wouldn't be able to give you an evidence-based protocol to be used on those cases. I would maybe do trial restorations in case for a couple of months to see if it's holding well. But to be honest, for those relatively severe cases, even quite a few of those cases which we have treated at university, we ended up with more sort of 360, we can call it today 360 veneers, but they resemble more to crowns, and restorations being cemented mainly to dentin. I'm not sure whether it is worthwhile to maintain dysplasic enamel that we don't really know how to bond to. But if it's not a very severe form, maybe you can try with a couple of test restorations as an let's say temporary solution. I personally don't like to go with permanent restorations, whether it is CAD/CAM or indirect in very young patients, because we are not in a mature environment. We still have growth. Teeth might undergo small movements. Soft tissue profile is not stabilized. So there are a lot of reasons that might basically disrupt the aesthetic integration of those restorations. So I like by principle to avoid placing indirect restorations in young patients. And that's why I would suggest to try why not with composite. Maybe don't start something very complex, maybe try on a few teeth. In a couple of months, probably you might see how those restorations behave. Use a multi-component adhesive. I would probably say it's better to be safe, and hopefully that will work for you. So thank you, Anna, for your interesting questions. Now, a question from Ula. How do you decide how much you will change the vertical dimension? Any stable points on model between incisors or any other? That is also something that I will show a little bit better next time. Today, as you understood, was more to present the different strategies for tooth wear, from preventive to interceptive and finally restorative. But in short, we normally try to create a new vertical dimension based on our needs in the anterior area. We want to recreate a better overbite, overjet, smile line tooth display. So it's a combination of aesthetic and functional parameters on the front teeth that will set up the new vertical dimension of occlusion. And normally that will give you, and that is an average measure, for the majority of cases, you end up with around 1.5 millimeter of space at the level of first molars. You rarely get more than this. And unless you start with an edge-to-edge position, class 3 tendency occlusion, where you can increase a little bit more the vertical dimension, because it will, let's say, the slight retrusion movement of lower front teeth when you open up will help you to recreate a better overbite and overjet. But if you start with somehow an ideal overbite, even with worn teeth, you can't open up too much, because you open vertically, but you also open sagittally a little bit and transversally as well. All this depends on your ability to maintain the same occlusal position, or possibly to move it a little bit forward, which is the opposite direction of what we have been always told to do. When you need to do an occlusal rehabilitation, as you certainly know, we're always said that we need to go into centric relationship. So we tend to be a little bit more posterior, especially if we have lost some dental references. But if you stick to the MIP, your maximal anti-cuspidation position, or if you follow the basic principles to restore the case in centric relationship, then your augmentation is strictly limited by the anatomy and by the occlusal relationship, anatomical and occlusal relationship between upper and lower teeth. So in general, the augmentation in the anterior area is, in the large majority of cases, below the 5 millimeters, which is considered as the maximum elevation of the video, which you can provide with nearly 100% adaptation from the patient. I'm sorry here. It's not such a simple answer, because the question is not, the question is very interesting, but very complex at the same time. So reference, it's given by the wax of them. You can do an index, a lateral index, an anterior index, but usually when we have defined on the models the new position, then we stabilize, we fix deposition with an index, a silicone index. Thank you very much. Now, the question from German. Good evening, German. Is there any alternative to abrasion or sandblasting? Oh, yes, of course. It takes a little more time. But what we try to achieve with air abrasion or sandblasting, we try to roughen the surface first, so it has a micromechanical effect on the hard tissues, but also to remove the aprismatic enamel layer that you have also not everywhere where you have really the contact, you might get some attrition and not much of aprismatic enamel, but where you end up with your restorations, you might have some aprismatic enamel. This doesn't provide very good adhesion. And you also have on the dentin the same phenomenon, hypermineralization of dentin, maybe again not where you have rapid wear, but in some other areas you might get some hypersclerotic dentin. And then you use fine diamonds, maybe regular diamonds on dentin, fine diamonds, a flame or a football-shaped burr, and you roughen the surface. The idea is to remove a couple of microns, maybe 10, 20 microns, in order to refresh the surface and to get really a clean surface to bond to. You cannot just place a rubber dam, do your etching, that will clean, of course, but it doesn't bring the exact same quality of adhesion. So I would say roughen. Maybe you can even use finishing disc, rough discs for some areas. That will take you a little more time, but nothing so terrible. So thank you very much, German, for your question. Now we have a question from Rula. If warranties have been already restored with composite restorations, do you take them off first? So that is very similar to one of the questions I have answered before. So in short, if they are well adapted, it's not so important their anatomy. You want to be able to confirm that they are fitting well on your bite wings or with transillumination, that you don't see any infiltration, no recurrent decay, of course, below those restorations, and that you have relatively clean occlusal margins. With sandblasting or with a burr, you can clean a little bit the margins. If you see that still the interface is not really clean, then better take them off. In fact, what you want is that you have a good cohesion between those restorations, which will be the base of your new restorations, and the fresh layer that you will place on top of them. So, of course, the quality of those restorations, and when I'm saying the quality of the restorations, it is also the interface between those restorations and the tooth structure is important for the longevity and the behavior of those restorations. Okay. So thank you, Rula, for the question. There is another question from German. When you replace with composite, you mentioned that you might get some chips or breaks. In this case, what is your bonding protocol to replace the broken surface? That is actually the protocol for maintenance. And what is maintenance? That's something that will come in the third webinar. I will probably already maybe in the second webinar. Maintenance means that composite, depending on the severity of parafunctional activities, depending on compliance of the patient, that is a very important factor. Compliance of the patient with the night guard and with your recommendations for the diet is a key element of success. If the patient doesn't do anything, you always observe to some degree a failure. And that might even be the case with ceramics, by the way. So ToothSquare is a team approach. Team approach, including the patient and the lab, of course. So there is the lab, there is a dentist, there is the patient. We can't get successful without a good teamwork. So in fact, The repair protocol or the maintenance protocol is the same as for placing restorations on existing ones, or modifying the anatomy, the occlusal anatomy, if you already have some restorations. Sandblasting, multifunctional monomer. It means classical multifunctional monomers or universal adhesives, because they have this 10 MDP multifunctional monomer that will help to get some chemical adhesion also on the composite. Sandblasting for micromechanical retention, and then you repair. It's relatively easy. I like to tell patients that we spend roughly maybe an hour every year, every second year, to maintain the restorations in good conditions. Okay, so thank you, German. Question from Martin. Good evening, Martin. Do you use a scanner to record and monitor tooth wear over time when you start treatment yet? Yes, we do it, I would say, only since recent time. I don't know if you have any access to the International Journal of Aesthetic Dentistry. We just had an article on the full molding technique that has been published in this journal. I was looking around, but I don't have the issue right in front of me. I think it is the second issue of the journal, 2020, and there is the follow-up with 3D impressions. Some cameras have a software that is designed to monitor tooth wear. It's a very interesting feature of, let's say, optical impressions. That was in a way indirectly feasible also with classical technology, but then you need sort of a scanner to monitor the difference between the previous impression and a new one. With of course 3D impression technology, this is very useful. Yes, definitely we do it by today. We like, for instance, when we do the impression for the night guard, then we'll do the impression with the optical camera, and then we can monitor down the road. You can make also, it is interesting, I would say, more from a scientific standpoint or teaching standpoint, not to say that clinical observation and dental photography is a key element. If someone doesn't have an optical impression scanner or camera, don't think you are lost. Absolutely not. Make good intraoral photography, and of course you will not be able to measure, tell the patient in microns how much material was lost over a given period of time, but you can very well show the patient the before, after the treatment, the post-treatment picture, and the new picture. And let's say for the follow-up of a patient in a private practice, this is absolutely feasible. What I think is maybe even more important than following up after treatment is for the patients who are in a preventive strategy. Then, when we see the patient for the first time, we might have no clue about the evolution. And optical impressions is an easy methodology to follow those cases before you install a treatment. Okay, so thank you. That was a very good question, Martin. Question from Ramona. Good evening. How do you establish the video before doing the direct restorations on lateral teeth in interceptive treatments? Do you have a wax-up before? Absolutely. I would lie if I would tell you that I didn't try once in a while to do it freehand, completely freehand. I've done quite a number of those cases, and at the end, knowing that the average augmentation of the level of first molars is about 1.5 millimeter, probably you wouldn't have tremendous problems to do it freehand if and only if, and no wax up, only and only if you have relatively uniform wear, which is normally the case mainly, not exclusively, but mainly with erosion cases. But you have some patients who show very asymmetrical level of tooth wear in between the upper and the lower, between one side and the other, especially some attrition cases. Bruxism and parafunctional movements might or are unlikely to be symmetrical. And then the amount of tooth wear is not equal everywhere around the mouth. And if you don't have a wax up, it's a nightmare because you have very limited reference and you might lose a lot of time to adjust, to level up your occlusion, get a nice occlusion, a nice speaker, symmetrical or regular equilibrated contact. I'm saying equilibrated, balanced contact. And this not necessarily because it might have from a functional standpoint or occlusal standpoint a major importance, but I like to get relatively balanced occlusal contact to distribute forces. For me, occlusion is crucial from a mechanical standpoint, more than in the perspective of creating a TMD. If we don't do things crazy, you will never bring a patient to decompensate in terms of occlusion if you get balanced contacts and you don't exaggerate the video change. And if you stay below these 5 millimeters, which we know from the literature, there isn't any big problem. So wax up is definitely a key element. From there, you can do a partial index or full index. I will explain you this during the second webinar. So thank you, Ramona. Good evening, Marina. Thank you for your questions. She's asking about her patient, I guess. Patient 45-year-old has tooth wear on the right side only. Just by coincidence, it brings me exactly to the point I made during my reply to Ramona. On the left crown, height is retained. What it may be, should we start treatment from posterior? Very briefly, to repeat what I said before, parafunctional activities are not symmetrical. Rarely, not to say never. Now, of course, depending on the biomechanical status of each tooth. Is it a vital tooth non-restored? Is it a tooth restored with composite, with ceramics, with a crown, with gold? That will trigger different wear levels. Next to the fact that for attrition cases, tooth wear is by nature rarely symmetrical. And that's the same for erosion. Depends where you have more saliva versus less saliva, you get more or less protection. So also erosion is not always perfectly symmetrical. You see some cases of erosion where erosion is strictly limited to a couple of teeth. You cannot even figure out how saliva or absence of saliva might allow teeth to be eroded only on one area. Or is the patient biting always with lemon or something acid always on the same teeth? Honestly, sometimes when you try to get an answer from the patient, it's very, very difficult. So when you get a single, let's assume that your case might have a crown, beautiful crown on the first molar, upper or lower, which is the most common place for having one crown in the mouth, and you want to treat the other teeth. In that situation, we do what I call a localized Dals concept. You restore all the other teeth which have to be restored, and the other one you don't touch. You will get passive eruption of the antagonist tooth and the one that you haven't brought to the same level as the others. And this is like for the Dals concept, this compensation, this spontaneous compensation shall occur normally in around 80% of the cases within a time frame which is highly variable. From the literature, it goes from 2 to 10 months. So just don't get in a hurry. but that's the best option we have in this situation. Okay, so thank you very much, Marina. That was a very good question. Now we have two more questions from Cartagena. Good evening, Cartagena. When do you start treating the appraxian lesions? The NLC, which means non-carious lesions, usually we see on lower premolars. Do you wait for a cavity to form, or do you do only preventive plus diet or contact lens type of composite? I think you have obviously a very good understanding about how we treat non-carious lesions. What is at the end the indication to restore those lesions? One could be dentin hypersensitivity. The second one is evolution. Is it stable or not so stable? And is it aesthetically creating a problem? Sometimes these non-carious lesions are being a little bit discolored. Pigments are staying there. So it is so simple because we don't need to prep. Normally, as soon as we have a little bit of volume missing, Baramsing a little bit, let's say from 1 millimeter and further, I would normally advise the patient to restore those lesions with no prep composite restorations. If you sort of seal those surfaces with very, very thin composite restorations, it's nothing wrong. It somehow is part of the preventive strategy. But if you document, you instruct the patients about using recalcifying agents like fluoride, amorphous phosphate, calcium. There are some other new products coming now on the market. This is also part of the preventive approach. But nobody can never, let's say, criticize you because you were waiting a little bit before making those restorations. So thank you for the question. And the last question from George. George, good evening. George's question is, how do you open the bite and establish the right amount of wax to properly restore each tooth? And also, if the restorations are high, how do you fix them in composite or lithium disilicate? Well, it's one question with multiple questions in. Basically, the amount of wax, of course, is directly related to the reference that will guide the change in the vertical dimension of occlusion. And again, this is your smile line, tooth display, anterior guidance, and anterior relationship, overbite, overjet. When you have set those 4 parameters, you have a new video in the majority of cases. From there, you just fill up the space according also to the amount of wear on different teeth. Depends also if your occlusal plane is perfectly regular or if you might have some discrepancies. So you try to reestablish the nicest occlusal plane in sagittal and transversal planes. So if the restorations are high, how do you fix them in composite or lithium disilicate? George, I would like to have more space than we have very often. And unfortunately, if you want to stick to the no prep approach, you can rarely go for indirect or even CAD/CAM solutions. So by today, if we stick to traditional or even current guidelines in regard to occlusion, which is to say we normally restore a patient somewhere around initial MIP, maybe a little bit more posterior, sometimes a little bit more anterior, but you can rarely, or we cannot say by today that it is evidence-based to move the occlusal position markedly in an anterior direction and end up with a stable occlusion. There are some technologies to basically evaluate the muscle behavior to see if the muscle seems to adapt to this new anterior position. That will give you a little bit more freedom to augment the video. In short, augmenting the video up to a certain point, you don't only have the vertical component, but you also have the sagittal component. When you increase more, you tend to separate also the teeth in a sagittal plane, and that is your strict limit. If you want to maintain anterior guidance, which is normally your absolute objective, you don't want to create an open bite, you can rarely use a no-prep approach if you stick to the lithium disilicate. But if your patient is an extreme bruxer, you might not have another option. And then, of course, doing a little bit of prep is in a way also a conservative technique, because you might then save more tissue than what you lost during the preparations. But it's never, again, it's a good question. It's a simple question, but it's never really, even when we need to make the decision, it's never that simple. Good. So that has been a very intense, discussion. Thank you for all the good questions. They were really very pertinent, and it has given me the chance to share with you a little bit more information than what I had the chance to share with you during the 1 hour webinar. Thank you, Sheila. Thank you, Ian. Thank you, Yvonne. Thank you, everyone. Thank you, Anna. Thank you to the Otixident team. Thank you to Alexander, who has done a great translation. And wish you everyone a wonderful evening or good night, because you're probably a little bit ahead of me with the time. Thank you very much. And don't forget, see you for the second webinar very soon. Bye-bye.